This is Dr. Andrew Kramer, Urology Associates, Cape Cod, and I gave this title because I only had two implants today. One was just a straightforward revision, and another one was a virgin or primary case, but at the end of the day, we realized none were easy, and this revision had nothing specifically challenging, except that every step required a lot of time and experience and patience, and I'll tell you why, and we'll go through the steps, but we cut right down, we see a tubing, it's right there, so we're going to trace the pump. Sometimes I don't go right for the pump. Here we do, and the break is right there. That black reservoir tubing has a hole in it. It's almost through and through. The pump is full of air, so clearly broken. So I think it's difficult because he's sort of got thick tissues, maybe a bigger scrotum, and he's got a lot of natural blood flow in the corpora, and you just have to contend for it. So to isolate the corpora, I backfill. The cylinders are intact. It was the pump that was broken. I backfill them, each one, and when I force fill them, it's easy to cut down on something inflated because it's much easier to find. It's expanded. Just like easier to put a tube in the bladder when the bladder's full, right? So you've got the full corpora, and there's no leaks there. And I cut down on them. You see, you have a clean incision on each corpora. So he's not tight enough. I'm going to take out. There's really no problem with the cylinders here, but they're not so easy to pull out because my corporotomy is different than the one that was there prior, some years ago. And it's got a rear tip extender on both sides. It sort of clings, but we get them all out. So cylinder one is out, and we're going to measure and dilate. And I don't even like to say dilate, just measure, get a good measurement. And this step, not particularly challenging, but it takes a little bit of experience to cut down on those inflated cylinders, take the cylinder out, rear tip included, and keep your exposure so you can measure and dilate and put it in a new cylinder. If you're just taking it out, you could go into it any which way, make an incision, just sort of pull it out and not worry about, what you do after. But in this case, you've got to expose the cylinder, you've got to get it out intact. You need a corporotomy right there. See, it's sort of diving away from us, but you got to make that intact because you're going to have to work with it in a reconstructive fashion. So you're measuring and dilating, and I'm going to get some deep measurements. By the way, in this case, we end up doing a drain and retain of the reservoir. We try to expose it and pull it and extract it, but in the end, it's just too deep. He's a thick guy, thick skin. He's got a big upper body, and it's not going to be possible to get it out safely. Could we do it if we had to? Probably, but risk-benefit, we don't. So new reservoir goes in on the right in this case because the left has the old one, the decommissioned one. They're not infected. We can leave it, but it's not worth getting out, and we can't put it in the same space unless we really had to. So cylinder one, cylinder two, we upsize them about an inch on each side. I'd be happy about that. And then the furlough device going through that incision in the corpora that we had to pull the other one out. Like I said, we have to maintain control of it, and we do. And he's difficult to measure because he's deep to the pelvis, he's very stretchy, and the measurement from before really has no bearing on the measurement today. It's totally different. We're a different corporotomy, different approach, different surgeon, and he's been cycling for some years, 8 years, so that's going to expand his penis. You got to account for that. So we're going to put all of the cylinders in. Pump is there. We're going to splice some tubing. Not going to show it. I plan on making a 2-minute video, but there's just too many steps, and I couldn't. So now we're going to put everything together and close those corporotomies and then splice off the extra tubing to the pump. And when we do that, then we're going to be able to expand his implant, pump it up. The pump and reservoir are going to be back together. They're not yet because you see that reservoir tubing just dangling right there up above. It's not connected to the pump. But now we're going to splice it all together. And once we do, we've got our pump low, deep, independent. We're going to go ahead and pump it up. I'm going to show you the good result. We're going to use a controlled expansion device here, and I think he'll appreciate the girth and the expansion he's going to get from that. But cylinders are in. I'm going to show you this, as I usually do, just to get a good view of how natural it looks, how good the result is, and great girth, thickness, straight as an arrow, and I like the location of the pump, and I like the location of the cylinder. So, I mean, that's really the important thing. You got to feel the tips, you got to feel the base to make sure there's no buckling, and I want to know when he wakes up and I talk to him, be like, yeah, I tested you, and the result was good. You got to be able to do that. And then you got to close in a way that buries the pump. And over the last probably 3 years, I've gotten so much more experience, and I think improved at burying all the tubing so that he doesn't see any of it under the penis. He did before. In this case, he doesn't. Andrew Kramer, Urology Associates of Cape Cod. Thank you.